And then let's we'll have to try and wrap it up soon, because we don't want people to get bored watching this video. But not that we'll get bored. I'm sure it's been fascinating. But in terms of things like patellofemoral joints, so that I think there's often a decision to be made. Even I think I'm right in saying even within total knee replacements, whether the surgeon replaces the kneecap, doesn't replace the kneecap. I guess that comes down to whether there's disease in the kneecap, and obviously if the kneecap's pristine, no reason to change it. But if let's say somebody has got wear and tear in their patella, is that a game changer in terms of having a total knee? Does that then mean they've got less, their prognosis is not as good, or again, what's your thoughts on that?
Well, Rob, opinion is divided. If you have isolated patellofemoral arthritis, there are surgeons who will look at the patient, and if the patient has end-stage arthritis, that means straight down to bone, and the tibiofemoral compartment is pristine. There is a group that will consider just isolated patellofemoral replacement. They'll do other things first, including the non-operative measures. Some will arthroscope the patient, some will inject their knee to see how their response is to the injection to the knee. And then there's a group who perhaps I was in that group until about 6 or 7 years ago, who looked at the literature and found that the patellofemoral joint replacement results were not very good. And it may have been due to design of the implant or a number of factors. And they found that the patellofemoral replacement was actually failing. And in those individuals, surgeons would opt for a total knee replacement. Now, if we're looking at knee preservation, that seems like a no-brainer. You've got somebody with just isolated patellofemoral arthritis. And some studies indicate it's 20% of the population of the knee patients. In my experience is less, certainly in my practice, less than 5% of patients have isolated patellofemoral arthritis. And I have, touch wood, been successful with patellofemoral, I tend to call it resurfacing, because when you replace the patellofemoral joint, you have to be accurate enough to make sure that you haven't pushed the patella outward, increasing the tension on the quads. Or that you haven't got a malalignment in which the patella slips off the side. So I tend to go for a patella resurfacing, but it's probably one or two a year for me.
Right. So that is a case of replacing the trochlea, is that right? And then putting a button on the patella, is that right?
Absolutely. And I tend to like to call it resurfacing. So I use an implant that sits in a crater that we've created in the femur, in a trochlea, and then a button. So it means that the forces across the knee hopefully haven't been changed. And in those instances also we look at the alignment, because if they've got isolated patellofemoral arthritis, there may be a malalignment. What I mean by it is that the patella might be translated laterally, increase the forcing across the knee, and that would have to be addressed too.
So as far as that patellofemoral articulation goes, though, and say in an isolated patellofemoral resurfacing as you just described, is that pretty much the same thing as you're doing in a total knee, or does that differ in a total knee?
It differs in a total knee because the femoral component is quite a large component, so it covers the trochlea too. And there are mixed papers on whether to resurface patella or not. And the conclusion, certainly in my experience, is based on the implant. This implant that I prefer to use, even if they have degenerative change in the patella, they can manage without a resurfacing of the patella.